Hey all, good afternoon. Very, very good afternoon. So hope everyone is having a good, Sunday, having good time. I see a lot of new faces, Naveen, Mapu. I cannot read out so many names because it will take the entire hour. So I will just go ahead and start with the class right away, okay? So I have about more than 50, 60 students. Thank you so much for joining. And myself, Dr. Rohini, and you can see that I am a graduate, postgraduate, both my MD as well I have done from Kasturba Medical College, Mangalore. And it is belonging to the deemed university, Manipal Academy of Higher Education. Okay, so this is a very nice deemed university with a very good campus. If you happen to get any seat there for higher education, don't leave the opportunity. Please join. It is a lot of fun. It is really nice place. And these are some of my additional qualifications. As you can see, I was in US for 10 years and I have earned a lot of, other side degrees as well, like medical transcription. And that was required because I was working in the hospital. And I also had to read so many reports. So I had to understand them. And there is hospital administration because I was given the administrative work. So that was my passion. If I'm not good at something, I'll just go ahead and do that degree and make myself, good for the job. And then I also did this PhD after I'm back in India, that is from the Savita University at Chennai. And I also have this embryologist, certification course. Both these I did at the same time. It, gives me that IVF and ICSI training. That is called ART course. And these are my degrees. And weekends, I have this freelancing work, which is like a change of job is rest actually. So if you get bored with one subject, you have to go to some other subject and study. That's how you should be, not just close the book and do nothing. So if you are bored with anatomy, go to biochemistry or go to some other subject like medicine, surgery, whichever. So now this is referral code. As you can see, there is the referral code is used by students to access free things like free products they can access, many nice things they can access. So please use the code wherever you are required to. All right. And that is for your good. And you also get this 10% discount. So 10% discount you get whenever you use the code, and that is with the plus and iconic classes. Okay. So you can enroll for all this and you get 10% discount with the code. So this ROHINI 10 probably works the best, and you try this also. It is both my name has it, is there in the code, so you will not miss it at all. All right, we have the first question. You have which ones innervated by the vagus? Now, which ones are innervated by the vagus? Now, tell me now, vagus now. Hello, everyone. Vagus is the 10th cranial now, right? Now, what are the things that it innervates now in the head and neck region? You tell me what it innervates. Anybody has any idea? There is pharyngeal muscles, there is stylopharyngeus, posterior belly of digastric, auricularis, occipitalis, temporalis. Now, muscles of facial expressions. These are from the second arch. So obviously, they're all supplied by the facial now. So that is ruled out. Okay. Anterior belly of digastric. Anterior belly of digastric is supplied by the mandibular now. And what about masseter? That is also by the mandibular. And occipitalis, occipitofrontalis, that is also supplied by the facial. Now we have temporalis by the mandibular. What about posterior belly? Posterior belly arises from the second arch. Anterior belly arises from the first arch. So this one is from the 7th cranial now. Yes, Raj. Then what about stylopharyngeus? Any idea? What about stylopharyngeus? It is supplied by Ninth cranial nerve. Yes, that is glossopharyngeal. Yes, glossopharyngeal. You're right. All right. Thank you, DDD. Thank you so much. All right, next one. All we are left with one single thing, that is pharyngeal muscle. So all these constrictor muscles in the pharynx are supplied by the vagus. So you have three constrictors. There is superior, middle, and the inferior constrictor. So all these constrictors are supplied by the vagus. So you remember it starts with the constrictor muscles and then it goes on to laryngeal muscles where you have the division of vagus. Now, what are the divisions of vagus? If you take vagus, the subdivisions are, anybody? Anybody knows what are the subdivisions of vagus? Branches of vagus? Superior laryngeal and recurrent laryngeal. Okay, superior laryngeal again divides into external and internal branches. External, well, let's take only this one and take it further. External supplies which one? External supplies only one muscle, cricothyroid. Whereas the internal, yes, supplies all those sensory supply to the mucosa plus other things. Like he said, other things. There is a list of things to do. All that is sensory. You just remember, and it doesn't supply no muscle. No muscle. So please remember, it doesn't supply any muscle. Rest of the laryngeal muscles are supplied by the recurrent laryngeal. Very important. But how many laryngeal muscles are there? How many muscles? We have 8 muscles. So out of that, 1 is supplied by this and 7 is supplied by the recurrent laryngeal, including the posterior cricoarytenoid. What is the function of posterior cricoarytenoid? What is the function of cricothyroid and posterior cricoarytenoid? These two are very important. Yes, Pratik, posterior cricoarytenoid is abduction. Abduction of what? Vocal cords. Okay, abduction of vocal cords. And cricothyroid, first always, tension of the vocal cord is first and then comes the vocalis which relaxes. So this is tension of the vocal cord. And what about vocalis? That would relax the vocal cords. What happens if there is a damage to external laryngeal nerve? Manish, what happens when there is a damage to external laryngeal? What happens to the voice? Does it become, yes, hoarseness. It is not monotonous, hoarseness. This one turns to monotonous and nasal voice. Okay, now I hope we are thorough in this. We have SK also after a long time joining. Yes. Okay, next we have glenoid cavity. Now tell me about this one. The glenoid cavity, we are talking about the humerus and scapula, okay, upper limb. So here we are talking about the glenoid cavity articulates with the head of the humerus by what? What kind of joint is that? Yes, it is very simple, ball and socket type of joint. Now, give me an example for fibrous articulation. This is the answer, you're right. Give me an example for fibrous articulation. What example would you give for fibrous? Yes, it is fixed and sutures and peg and socket. That is the tooth in this socket. So that is gomphosis. Very important. Next, cartilaginous, give me an example. There is primary and secondary. Give me one example for primary, anybody? One example for primary. Primary, it is manubriosternal. sorry, the sternoclavicular is primary. All right, this one, manubriosternal is secondary. All those midline joints, including the IV disc, is all secondary. Next, plain synovial joint. Anybody plain? Which is a plane? Intercarpals. Knee is not plain. You're talking about patella. Patellofemoral is plain. Yes. Knee is condylar. Knee is condylar joint. What about the ball and socket, hip and shoulder joint? So we have hinge joint. Anybody? Yes, you're right. Knee and ankle. Elbow also. Yes, elbow also. So what is the criteria that you can think of when it comes to the synovial joint? What should be there? The criteria for synovial joint. Criteria for synovial joint is the capsule. Remember, the capsule lined by synovial membrane is the criteria. That is very important. Next, this is the classification: fibrous, cartilaginous, synovial. We covered it all, and you know that this is what kind of classification is this? This is structural. According to structural classification, we have all this. But when it comes to functional, we have, depending on the movements. So there is arthrosis. It is diarthrosis. What is diarthrotic? It is two movements. Okay. So like that we have functional, but we don't, even look at the functional part. We only talk about the structural. So let's not get into that. So now clinical case scenario, we have one. This is a question. Hashmin is a 65-year-old manual worker. He is brought to the renal unit for hemodialysis. Doctor plans to perform central venous access with a catheter. Now, what is the best vein for central venous? Why? Why is also a question. Now, subclavian is also possible, internal jugular, external jugular, anterior, brachiocephalic. Which one? Why, Pratik? Why did you pick the B? Ujjwal also says it's B. Yes, the ones which have a, narrow lumen, the ones which have narrow lumen and the one which have more, tortuous course or curvy course, or if it is not a direct course, then it is not a good choice for central venous catheterization. So in this case, let's see what is the answer. So the answer here is B, of course. So here you have the explanation for this. We already said what is the explanation. So here, why do we use the central venous catheterization? One is to administer some medication, to obtain some blood for the blood test, and also to measure the central venous pressure, and also to administer any fluids, okay, which cannot be administered through the mouth. And these are some of the indications. You can see long-term intravenous antibiotics and nutritional in chronically ill persons if you want to administer, then long-term pain medications, chemotherapy, and we also have the dialysis listed. All right, let's move to the next one. So it is internal jugular approach. So now the positioning is told. It is, what is Trendelenburg position? Anybody, any idea? Trendelenburg? It is like, this position. Head down position. So you tell me which one, head is elevated or head down? Now who is right? Pratik is say this side is head or this side is head? Head is elevated. Yes. So here, right side is preferred. Why right side is preferred? Any idea why right side IV jugular approach is preferred? Right side is preferred than the left side. Why? Yes, right side it is because of the formation of internal jugular. How is internal jugular formed? First of all, internal jugular formation. There is external jugular and internal jugular. How is it formed? Internal jugular. External jugular, it is very simple. It is formed by anybody. Anyone has an idea internal and external jugular vein formation? This is P and P. What is P? Posterior auricular plus posterior division of retromandibular. Right? What about internal jugular? Anyone? Sigmoid sinus? Inferior petrosal sinus? Then ultimately where it joins the facial vein, also joins this, and they form the internal jugular vein. Okay, so you should remember continuation of that is inferior petrosal sinus. Now here needle placement where it is approached and locate the triangle formed by the clavicle, and the two heads of the sternal and clavicular heads are there, and the small triangle that is formed between these two you have to look for. You have to put the 3 fingers of left hand on the carotid artery and place needles at a 30 to 40 degree angle. So all this you all have done, so you know. And all right, there is a small note here, that is there is no elevator to success. You have to take the steps. Nice, right? So just put it so that everyone gets some motivation. So we have to go step by step. There is nothing like a shortcut route in studies. When it comes to studies, you are responsible for what you do. And we have some dedications, and I also have included SKs here, and you can see, and all your dedications are there. And we have brown hat from Suman, we also have orange hat from Faisal, and all these hats and many more which are coming my way are all welcome. And this is the profile picture with the the followers. All that is actually, this is an old number, so we have some more followers, and more the number of followers, we are at a better ranking. So that is going to put us at a better place. And I want to thank all of you who have wholeheartedly supported this. And this is some special class features. And what are these features? Like special class, you have interaction. Now I immediately noticed who is there, who is not there. But in the case of YouTube classes, that is not so, because you feel like you're a fish in the big ocean. So here special class gives you more interaction, more of the depth in the subject. And also you can raise your hand when you want to ask some question, and you'll never miss a class because you will get the notification also. And there are lecture notes which you can download, and anytime you can access. So these are some of the luxuries of the special class. And you have some upcoming classes every day at 5 p.m. So you can look forward to the classes except for Sunday. So every day 5 p.m. default to join me, please. So I'll have some nice questions like MCQs and the topics and images. All these we are going to discuss. For if I take up some topic, and we are going to discuss all those MCQs related to that. So now here is the launching 2 months subscription, 6750 only. You all have heard of this, and there is very little time for your exams, and you know that the time is very crucial, and that's why the introductory offer here. And plus subscription will give you all these extras like the daily live classes are there, structured courses, unlimited access, and tests and other series. All this is very, very important because you will know where exactly you stand in terms of preparations. And you also have Iconic, where you have both the Unacademy and PrepLadder access. And you also have the 4-year subscription for those who are in undergraduation and want to have a firm foundation to PG. So this is very important. And the amount for the plus is 60 and here it is 75. And this is really a small amount when you compare with the access that you can get with the 4-year subscription. And this is the new feature that has been added, like raise a hand, where you can raise a hand and ask questions to the educator, and the educator would solve your queries, and not just you, the whole class gets to listen. And this is last mile to NEET PG, where all the educators get to, take different classes. All the 19 subjects are cleared here. And you can see me also, I have covered the anatomy classes, and it started with anatomy. And we have something similar coming up in the future also. There is integrated clinical batch where 2 subjects are integrated and dual educators are presenting this. It is a 2-hour duration course and main 2-hour duration class actually. And many subjects are integrated. You can see anatomy here with the ortho, medicine, ENT, all these. There is integrated clinical batch NEET PG, where you have MCQ based learning. That is also very interesting. And you can see focus FMG batch, where the educators will not just interact with you, will give you integrated approach to many subjects, but also you are going to get the recorded sessions in case you have missed the class. And also PDF is something that you can always download whenever you have attended and subscribed. And this is the plus and Iconic subscription EMI options. 48 months will attract only 1125, and here 1406, where you are supposed to use the code. Use the code and you will be able to access it. So please do so when you want to go for EMI. This is a no cost EMI. And here a big thank you for listening to all this, and let's move ahead. All right, so we have a surgical. Yes, Ujjwal. So now surgical neck of humerus is related to radial nerve, axillary, ulnar, median, none of the above. Which one? Surgical neck of the humerus. The answer is axillary nerve. Okay, what is the root value of axillary? Anyone? Manish, root value of axillary? C5, C6. Okay, C5, C6. Root value of radial, all of them. C5, C6, C7, C8, T1. Ulnar, C8, T1. Median, all again. And this too. These two alone. Okay, why would I do that? I would just do it here. So when the person has this palsy, clump case palsy, okay, so which root is involved? C8, T1, C8, T1. All right, so here you have to remember C8, T1 is involved, and what muscles are involved? What muscles are involved in this case? Ulnar. So ulnar is from the lower trunk. Yes, so you can remember this with this clump K monkey hangs down from lower trunk. of tree. So you remember this, and clump K you'll remember, and lower trunk you'll remember. So both you can remember. Intrinsic muscles of the hand. Yes, intrinsic muscles. When it comes to intrinsic muscles, which are intrinsic? Intrinsic muscles are, there are thenars, there are hypothenars, and there are lumbricals and palmar intraossei. So we have thenars 3, we have hypothenars 3, lumbricals 4. Which are they? 2, 3, 4, 5. Palmar intraossei 3. Palmar is not there on which 2? Thumb, not there. Middle finger, not there. Okay. Dorsal. Dorsal has 4. So which one does not have? The thumb side, no. This is that. So now here, there is one muscle called opponents. Okay, opponents is supplied by which nerve? Very, very important. Many times it has been asked. Which nerve? This is thenar side. Opponents is supplied by which nerve? Opponents pollicis is supplied by median nerve. But to go a little more in detail, which branch of median? Which branch of median nerve supplies? The recurrent branch. Yes. So you have to remember it this way. Next, hypothenar. There are 3 of them. Here there is also, again, there is a opponents, digiti minimi, abductor, and now here also you have opponents. But all these end with digiti minimum. All of them are supplied by ulnar. All right. So now here lumbricals. Lumbricals arise from which muscle? Which muscle? Flexor digitorum profundus. Flexor digitorum profundus. So there are 4 of them. These 2 are supplied by the median and these 2 are supplied by the ulnar. Now, PAD, adduction. So palmar intraossei will do the adduction and dorsal will do abduction. So which one is bipinnate? All of them bipinnate. Which ones? Is it palmar or dorsal? Bipinnate muscle. Yes, it is dorsal. This is the bipinnate set of muscles. Okay, now what about palmar? Are there any unipinnate here? Which ones? There are 3 of them. Palmar. The one on the index finger is unipinnate. All right, next one. Okay, now what do you see here? There is surgical neck. We talked about the axillary nerve in the question. You can see the surgical neck. You can see the lesser tuberosity. And what is the attachment of lesser tuberosity? Any idea? Attachment on the lesser tuberosity? Lesser tuberosity gives attachment to the subscapularis. Subscapularis. Okay, what is the action of subscapularis? Any idea? Subscapularis it is one of the rotator cuff. Yes. Medial rotation. Medial rotation, as someone said, and it's already moved. So medial rotation. And before Manish, someone else said medial rotation. That is the action of subscapularis. All right. So you remember there is supraspinatus, infraspinatus, and subscapularis, and teres minor. Most of the time teres minor is asked, and I don't think anybody would bother to ask infraspinatus and subscapularis. It's very simple. The supraspinatus is asked most of the time. Teres minor is asked. What is the action of teres minor? Of course, it is with the major, so it would also do adduction. That is one action. And what else? There is one more action. What other action? It just looks like two opposite actions. Anyone? One is adduction, of course, because teres major also does adduction. What is the other action? Lateral rotation. Yes, lateral rotation. No, it is lateral rotation. That's why I said it is opposite. Lateral rotation. It does the lateral rotation and adduction. It is supplied by the axillary nerve. That's why I wanted to mention this axillary nerve. And why? Whenever we want to check the injury to axillary nerve, we don't consider teres minor at all, right? We only talk about deltoid. Any idea why teres minor is not considered? Why teres minor is not considered? Where is teres minor actually? Teres minor, now if I draw a scapulum. Okay, so if this is lateral side, this is the medial side. Okay, so you should be able to see the spine here. Also small extension, coracoid process. This is the supraspinatus, infraspinatus. And here I would remember T. And here I would remember okay. Levator scapulae, rhomboidus, major, minor, and latissimus dorsi. And this one is for which head? Long head of triceps. And here also long head biceps, long. And there is teres major and minor. So, but since it is on the lateral side, of course it is supposed to know all these things. What do? They do the adduction, and it also does the abduction. It is a very small muscle. It is very difficult to make out. It is overlapped by the fibers coming from the serratus. The serratus actually comes from this side, the medial border. On the inner side, medial border, you have serratus anterior. So that serratus overshadows this teres minor. So that's why you cannot see the action of teres minor, and it is not very well executed. That's why we don't consider this muscle much to check the action. So we have the deltoid doing the similar action, that is abduction. Okay, so this is what is checked for axillary nerve injury. So you can easily make out the contour of the muscle also changes, and the action abduction you can make out. If the person is unable to do abduction, you know that there is an injury to axillary nerve. Okay, let's move to the next one. Okay, Shashi. 65-year-old lady was brought to the renal unit for, again I'm stuck with the renal unit for hemodialysis. Now doctor plans to perform central venous access with a catheter. So now here, internal jugular vein is accessible for puncture or catheterization. Where exactly? We already discussed this, but let's see whether you can recall where exactly you should be looking for internal jugular vein. So is it at the jugular notch, occipital triangle, omotracheal triangle, posterior cervical region, or lesser supraclavicular fossa? Which one? Vishwa, Mohammed, which one do you think is the answer? A, jugular notch, because we already mentioned, we talked about sternocleidomastoid, two heads, and we talked about the, two heads of the sternoclavicular head and sternal head, all that we talked about. So you should be knowing by now. So this is the jugular notch. Yeah. Near the jugular notch. So this is sternocleidomastoid. Now just let's talk about sternocleidomastoid and subclavian vein and artery. Now you can locate this subclavian artery vein, and it is right behind the clavicle. So right behind the clavicle, and you can also see impression of these vessels over the posterior aspect of the clavicle. Okay, so whenever there is a fracture of the clavicle, the first thing that could get injured is the subclavian vein. Okay, because of the thin wall, that is one thing that can get easily punctured. And you can also see the sternocleidomastoid. What's so special about sternocleidomastoid? Now, there is a condition called wry neck. That is one thing you can list here. And you can also talk about the mastoid process. Okay, very well developed mastoid process is because of the action of sternocleidomastoid. So that is one thing. And one more thing is, those in dancers, they say that even in dancers, okay, who use their neck muscles a lot, and they also have the mastoid process very well developed because they use this sternocleidomastoid. What are the attachments along with the sternocleidomastoid on the mastoid process? Along with the sternocleidomastoid, you remember, just like, see, before when we were in 10th standard, it used to be called SSLC. Okay, it was not 10th, it's not CBSE board, it was different board. So it was state board. We didn't have those CBSE boards before, and we had the state board, and it was called SSLC. And you remember SSL. Okay, cut off that C. That is the attachment on mastoid process. What is that? It is sternocleidomastoid, and it is splenius capitis and longissimus capitis. Splenius capitis and longissimus capitis. All right. Next one. Okay, so we have a question: which internal jugular vein is preferred for catheterization? We already talked about this right internal jugular vein. We talked about this just now. All right, because of its wider diameter and it is more superficial than the left side, and right-sided approach is more acceptable than the left-sided one for such procedures. And next one, okay, moving little quick. Now the deltopectoral groove contains, where is this deltopectoral groove? Between the deltoid and the pectoralis. So there is a groove, and it is traversed by a vein, lymph node, deltoid branch of lateral thoracic. Think which one? So many of you think it is just B. Why Ujjwal thinks all of the above? So many things in the one single groove. Lateral thoracic, why it should go? The groove is like this. Why it should go in that direction, lateral thoracic? Lateral thoracic is like this. So that is not the answer. Cephalic lymph nodes, axillary lymph nodes don't go that high. So that is not, it is. Now tell me which one is there in the deltopectoral groove. The answer is B. The answer is B. Okay, so the answer was, what was the answer? Cephalic vein. Cephalic vein was the answer. Now here you can see the cephalic vein. And if you trace the cephalic vein, where else you can trace it in the hand? Where do you trace it in the hand? It is seen in the anatomical snuff box also. That's where you can see two places, important places you can see. Anatomical snuff box and another one in the deltopectoral groove. And ultimately, where does it drain into? So you can see that it drains into, what is this vein here? We can see the vein here. Which vein is this? It drains into the subclavian. So because here is the brachial, it drains into, we should have done the pole, right? We should have done the pole. Okay. But I don't know whether I have ABCD or whether I have true or false. Let's pick this one. That is not the answer. B, right? Okay, Ujjwal said that. All right, next one. So this is ulnar. You can see the ulnar. You can see the, what about median? Any idea? Let that get over. Median nerve lies over which artery? Median nerve lies over which artery? See, you can see the median nerve here. It lies over which artery? It is not brachial artery. Brachial artery is way too, away from the region. You can see there are two roots. Okay, median nerve is formed by medial root and the lateral root, right? And you can see that it forms a V-shaped structure before it joins to form a single root. Now here you can see that it lies against the axillary. Now you can see that here. That is the axillary artery. Later on it continues. After this, which muscle is this? Teres. Teres major. Now here after that you can see, sorry, the pectoralis. What did I say that? This is pectoralis minor. Okay, so here you can see later on it turns into brachial. So here it is brachial after it crosses the teres major muscle. This is pectoralis minor. But see in this region, you can see that it lies just above the axillary artery. So you should remember that axillary artery lies in very close proximity to median nerve. All right. So in case of, there are so many variations, like there is a case where the musculocutaneous nerve is absent. I myself have, come across so many cases where the musculocutaneous nerve is absent bilaterally. So what happens with that area, arm area, flexors of the arm are supplied by which nerve in that case? Flexors of the arm are supplied by which nerve in that case? Anybody? It is supplied by median nerve. And there is also many papers where the median nerve and ulnar nerve are, joined. Okay, by a small root. All right, next question. Let's go to the next question. Back of the medial epicondyle is related to. Back of the medial epicondyle is related to. Which one? Ulnar nerve. Let's see. See, the options are not given like that. That's why it is difficult to create the poll. This particular MCQ has different version. So here it is the ulnar nerve. We have the ulnar nerve and it lies right over the medial epicondyle of the humerus. So now here in supracondylar fractures, you should remember median, the ulnar nerve is the one which can easily get damaged. So now there is supracondylar fracture. What other structures can get damaged? One is the brachial artery, right? Brachial artery. What else do you think can get damaged in the supracondylar fracture? That is just above the condyles of the lower end of the humerus it is. What other structures lie in this area? Supracondylar fracture. So that results in Volkmann's ischemic contracture. Volkmann's ischemic contracture. So supracondylar fracture. So that is what brachial artery damage, that is going to result in Volkmann's ischemic contracture, and the other thing is the nerve that is present in this region. So it is the ulnar nerve. It is superficial ulnar nerve also could get damaged. All right, in this case, the medial epicondyle is located on the distal end of the humerus. You have medial epicondyle is inferior to medial supracondylar ridge. That is the second point. It is proximal to olecranon fossa and it protects the ulnar nerve, and there is a groove, okay, that lies in that. Now coming to medial epicondyle itself, what are the attachments or what muscles take origin from medial epicondyle? Okay, which group of muscles? There are flexors and extensors coming to the forearm. So which one? Flexors. Now can someone name the flexors? Name the flexors of forearm. Flexors of forearm. I have how many F? This is superficial. This is D. 2F, 1P, 3F, 2P. Okay, so it's as simple as that. Now list them all. Now which one is this F? Which one is this? You start with the flexor carpi ulnaris. Then flexor carpi radialis. Then we have flexor digitorum superficialis, pronator, teres, and palmaris longus. You can go in order. This one is flexor. Anybody? Digitorum profundus. What is this F? Flexor longus. What is this P? Pronator quadratus. Isn't this easy? You remember this. Okay, but what about the extensors? You can remember B. And then you have all these are the extensors. All these are the extensors. Okay, so just list them out and you should be able to get all the extensors in. So it's like B and then SAEE. So these are the extensors. Now, continuous repetitive movement of these extensors in case of like, tennis elbow, this is the group of muscles that, get injured, and that is extensors from the lateral epicondyle. And flexors come from medial epicondyle. This is called tennis elbow, that is called golfer's elbow. But what is student's elbow? What is student's elbow or Popeye elbow? Have you heard of this word, Popeye elbow? What is this then? Has it got anything to do with? This is not medial epicondyle. It is, yes, olecranon bursitis. This is olecranon bursitis. Okay, next one. Axilla contains all of the following except. Axilla contains all of the following except. What does it contain? Axillary artery, axillary vein, trunks of the brachial plexus, and fat. What it doesn't contain? Axillary vein, it does not contain. Pratik says axillary vein. Okay, let's see what is the answer. The answer is trunks. See the trunk. Where is the trunk? What is the sequence? I would remember like this. Are you tired? Drink, coffee, buddy. Roots, trunks, divisions, cords and branches. But we can only see cords and branches, okay, in the axilla. Not these. These are much above. So only cords and branches. So we are talking about trunks. That's why you have to read the question clearly. You have to be careful when you read the question. The answer is C. Yes. So now here, the cords and branches of the brachial plexus, contents of the axilla. Like I mentioned, axillary artery and its branches you can see. Vein, lymph nodes, lymphatic vessels, fat, everything is fine, and also lots of loose connective tissue. See, this is the median nerve I was talking about. It lies over the axillary artery. You can see that V here, there is this V. That is a median nerve. All right. Okay, so now what else we can identify here? Okay, this is a cephalic vein. And it drains into subclavian. All right, so you can also see the axillary sheath covering the axillary vessels. Now the bicipital groove, next question, bicipital groove of the humerus lodges. Bicipital groove of the humerus lodges, which one? Axillary artery, long head of biceps, long head of triceps, coracobrachialis, none of the above. Bicipital groove, B. Biceps, long head. Okay, so now let's see the answer. Remember I said it is from the supraglenoid tubercle, and this is the bicipital groove, and it comes over the bicipital groove, and you can see that it is between those two tubercles, and then this is the long head of the biceps, and that is the short head of the biceps. What is the other function of biceps? Other function of biceps. Other than flexion, what is the other function of biceps? Supination, yes. So supination is done by biceps as well, along with the supinator muscle. Supinator is supplied by which nerve? Supinator is supplied by which nerve? Anybody? It is in the extensor compartment. So think, supinator is supplied by which nerve? It is supplied by the radial. But which branch of radial? Anybody? It has a deep branch and a superficial branch. Now there is one branch that runs between the fibers of supinator. Which branch runs? It is the superficial branch. Okay. Next one. Muscles taking origin from the clavicle. Think of all those muscles that take origin from the clavicle. So we have subclavius, yes. There is trapezius. Is trapezius taking origin from there? We are talking about origin. So think of only origins. Pectoralis minor, all of the above, A and B only. Which one do you think is the answer? We have to think of only origin, not insertion. A, subclavius. We have to think of origin. Trapezius origin is, how can trapezius have an origin in the clavicle? Pectoralis. Okay, so we'll see what is the answer. The answer is C. Answer is C. So you have the origin of sternocleidomastoid, we have pectoralis major, and we also have the deltoid origin. Okay, the deltoid origin. So this, remember this, the trapezius is insertion. The answer B, what you picked, was insertion. So you also have all these muscles. Now here, the answer is pectoralis major. We are not talking about minor, we are talking about the major. So it not just has on the clavicle, but it also originates from the sternum. Okay, there are fibers coming from sternum as well and clavicle as well. What is the action of, let's see each action. What is the action of pectoralis major? What does that do? A, what does that do? Is it adduction or abduction? It does adduction. Okay, what about trapezius? It is from the external occipital protuberance plus all the vertebrae, cervical C1 to C7 plus T1 to T12 is the origin. And goes where? It goes to the acromion process and the clavicle. Now the subclavius. What is subclavius? Subclavius has a very small, group of muscles. So that is again very few fibers, subclavius. Or it comes into the category of those muscles which just stabilize the joint. Okay, it is neither a prime mover nor an antagonist. It is just a fixator. It is a fixator actually, muscle. So what do you think is the action of subclavius? It is also adduction. And it is covered by a fascia called clavipectoral fascia. Okay, along with the pectoralis minor. So all this is covered by clavipectoral fascia, the subclavius and the pectoralis minor. All right, let's go to the next question. One of the following is a branch of second part of axillary artery. So first part gives one branch, second part gives two branches, third part gives three branches. What is the first part branch? Anyone? First part branch is only one. Which one is that? Superior thoracic. I gave you a hint. Superior thoracic. Second one, of course, whatever you said. Lateral, thoracic, and one more. What is the other one? What's the other one? And the third one has three branches. This is from the third branch. This is from the third branch. This is from the second one. This is from the first one. And this is also from the, third one. All right. So these are the branches from the first, second, and third. So here we have to just fill in the blanks. And one of the following is a branch of second part of axillary artery. So this is the one, lateral thoracic. So here you can see lateral thoracic. It is the branch from the second part. So here we have thoracoacromial, other one. These two are from the second part. And then we have three here. These are from the third part. And there is one here that is from the first part. All right. So we have all these branches, total of 6 branches from the axillary artery. All right. So with this, I almost come to an end, and I would like to thank all those who attended this. And next time, yes, I will have questions which has got the poll. So it will be even more fun. Okay. I'll bring in those questions which we can have for a poll, and it will be even more interactive and nice. All right. Thank you, everyone, those who attended. And please follow my profile and let me see your messages as well. Thank you so much. You have a good day. Bye.